Next up, we welcome Naveed Sharif, Director of Data Science and Web Analytics, and Jeff Groesbeck, Data Scientist at Kaiser Permanente, who will take us through how causal AI is redefining the patient care, healthcare management, and insurance across Kaiser Permanente's fully integrated healthcare model. And please keep your questions coming on Slido. Welcome.
All right, well, I don't have an interesting joke to share, but I think I got a pretty interesting poll to ask. I think the first question I want to ask the audience is, how many people are from California? Just a show of raise of hands. Okay, so a lot of people are from California. Out of those folks, how many people have either had a Kaiser healthcare plan or currently have a Kaiser healthcare plan? It's actually not that bad. Northern California, the interesting statistic here is that in Northern California, 1 out of 3 individuals are currently insured through Kaiser's healthcare plan. So it's a huge dominance within this Northern California region. My name is Naveed. I lead a data science team within Kaiser Permanente. I'm excited to share with you guys how we're leveraging causal inference to design and improve some of the digital products that we are in currently. We're in the digital department. And specifically, we're going to see the application of causal inference within a fully integrated healthcare system. And so not that many people might know about that, but we're going to dive into that before we get into a very interesting use case topic with Jeffrey in a little bit. So from this presentation, the 3 things that we'll probably learn is how we're using it to design digital products. The second thing is how our focus in causal inference is patient care and the quality of care that we're providing. And then the third thing is how it's very important for us to safeguard our interventions. A false positive within a healthcare system is a huge impact with our patients. So before diving into causal inference and how we're applying it within Kaiser Permanente, I think it's really important to first level set by understanding what is the dynamic of healthcare within the States. And I want to explain it through 3 core ideas. The first is healthcare evolves dramatically as we age. For example, in my own personal experience, I have a young son at home. A lot of the experience has been around going into a pediatric office and looking at growth charts and getting immunization shots and my baby crying and screaming. But those are the first series of experiences that I have. The second thing is I have aging parents that have aged into Medicare. Medicare is a very different coverage from something that maybe your employer is giving to you guys. And then the third thing is there are some unexpected challenges that do happen. My father was diagnosed with Parkinson's, and so searching for specialists and specialist care it's a challenge. It took us a lot of days of finding out what is the right type of specialty of care for my father. So that's the first core idea. The second core idea is there are some really important decisions that you have to make that impact the quality of care that you're getting and the type of care that you're receiving. And so the first thing is the insurance selection. And so that insurance selection, it dictates the type of providers you have access to, the type of services that you actually have, and then also impacts the type of finances that might be due based on the services that are rendered to you. The other piece is, from a decision point, is the provider selection. If you think about the provider selection, you can go through a fully integrated healthcare system like Kaiser Permanente. You can go through an in-house network like Sutter Health or John Muir, or you can also go through a private practice. Now, the third core idea within this healthcare system is to understand really how fragmented the healthcare system is. We talk about all these areas from shopping to accessing care to delivery to managing care. A lot of organizations are not under one umbrella. They don't talk to each other. They all have their own initiatives and objectives as well. But us as patients, we don't really, I think, differentiate that as let's say corporations tend to do. All right, so that kind of leads us into a fully integrated healthcare system. So what is a fully integrated healthcare system? It's everything that we just saw, like insurance, shopping for insurance. It is the hospitals and facilities where you're receiving care. It's the insurance, hospitals, and the clinicians, obviously, the clinicians and the doctors all under one umbrella. Now, there are some advantages and there are some challenges. We'll see actually both of those advantages and challenges in one of our use cases. The first advantage is that enhanced coordination. I really want to dive into this. So imagine you're a patient, you have some issues with your eyes, and you go and see an optometrist. That optometrist can actually log into the electronic medical records. It's like your chart, and they can actually see the notes that an ophthalmologist maybe entered for that patient. That ophthalmologist might be able to also access, when you did see that ophthalmologist, the logs or notes that maybe their primary care physician had entered. So all that's collectively within your charts, and so there's that enhanced coordination that exists under a umbrella of care, such as Kaiser. The other advantage is the data richness. This truly does benefit our clinicians. We talked about that, how they're able to access some of that information. It also benefits our researchers. But I want to double down on this with how rich our data is within a fully integrated healthcare system. So we talked about those different components from premiums and claims. All of that is managed within a fully integrated healthcare system. We do have access to that information. We talked a little bit about your charts and the electronic medical records. All of that also you're able to access. There's also digital data, right? The interaction that happens digitally on our webpage, you're able to access that. And then also just the hospitals, the facilities that you have access to, what type of clinicians you saw, that those data points are being captured as well. Now, the other key thing here is, and this is in most healthcare systems, there's not that much churn, right? Usually you stick with your doctor, you're happy with your doctor, you're not really moving around. And so we have these large longitudinal data sets of individuals, literally from their cradle to their grave. And so I think that's a very unique thing within a fully integrated healthcare system as well. Now, the challenges do exist. The first one is, and this is probably what we're most known for, specifically Kaiser, is the geographic constraints. So if you are in a location and there are not that many hospitals in that location that you can have access to, it might be very difficult to get some sort of specialized care that you would want to get for whatever condition that you're going through. The second thing is the complex management. Since these three pillars exist under one umbrella, there is a lot of conflicting interest within these three areas of that umbrella. And so it is a little slow to push innovation or technology within that area, and that does exist, and it is a hurdle for sure from a bureaucratic perspective. All right, so let's start jumping into some things that we're doing with Causal Inference within the digital department. So the first thing is that just like a lot of folks and a lot of folks talking about their orgs, we do have an A/B testing environment. And so a lot of the digital products that we do launch, it is anchored to Causal Insights. It's based on a Bayesian framework. One of the big reasons why we chose the Bayesian framework was because of a lot of the contextual information that doctors or clinicians might have that you could pass that on to priors. The other thing, and so this is basically a review, and then the other thing to understand about these A/B tests that we do run, we're in digital, so we get to scale across those three arms, the three verticals of healthcare. And so when you're able to scale across those three verticals, you're able to really expose a lot of different metrics and impact that you have. So from an operational perspective, like call centers, from a clinician perspective, like burnout, we'll talk about that in just a moment, from a patient care perspective, from an engagement perspective. And because you have that much visibility, you actually can also place, I didn't hear that much about this in A/B testing, the right type of guardrails. Guardrails are really, really important for us within Kaiser Permanente. Now, as you guys know, you can't run experiment on everything. In fact, there's a lot of limitations in healthcare, and so quasi-experiments is really where we start to work into. And quasi-experiments are actually pretty effective within a fully integrated healthcare system within Kaiser, because we do have not that much censored data. Data does exist, it is censored, but we get to follow these patients, again, throughout their lives. So, for example, for my father or my parents who've aged into Medicare, when you're transitioning out from your previous insurance plan into Medicare, let's say, if you're under Kaiser, you can follow that. And so you might have not needed to change doctors or clinician staff or a system. That is all being followed. Let's say my parents then wanted to do some physical therapy. That engagement with that physical therapist is also captured. So all those events are actually captured within an integrated model. Now, confounders do exist, or unobservables do exist, but there is, I think, a lot of ways to control for some of the confounders. Again, we do have a lot of access to those data points. Now, before I hand the mic to Jeff, who'll get into a specific use case where we're going to really start to surface some of the advantages and challenges within Kaiser Permanente, or a fully integrated healthcare system, I want to talk about what we've been spending a lot of time on. And so post-COVID, there has been a huge influx of utilization within our healthcare system. And so clinician burnout is a real thing. And so one of the things that we want to measure is how do we actually reduce that burnout? And then also, what type of impact might it have on our patients? And so some of the things that we do are like, how can we reroute messages that are maybe sent to your primary care physician? Something else to keep mindful here is that primary care physicians are kind of like the gatekeepers. And so they are getting a lot of messages, or they're getting contacted quite a bit. So if we can actually reroute some of the messages, like to an optometrist or ophthalmologist or a dermatologist, that should reduce the amount of work that a PCP might have. All right, well, I'll go ahead and pass the mic to Jeff, who will dive into ARCS notifications. There you go, Jeff.
Awesome. Thank you, Naveed. All right. Let's dive in. Okay, so we're going to talk about prescription notifications. So a long-standing question from the pharmacy arm of Kaiser was about, they were wondering about the impact of refill reminders, and specifically around medication adherence, but also medication overutilization. So just to give you a brief context, so refill reminders are either SMS, push, or email notifications sent to members when their prescriptions are eligible to be refilled. And this was introduced as an opt-in feature on KP.org to members in late 2020. And so in terms of the data that we're going to use for this study, I'm going to focus on a single maintenance medication used to treat hypertension. And it's one of the most prescribed medications at Kaiser Permanente, and is dispensed at 100 days supply typically. In terms of scope, we're looking in Southern California. So like Naveed mentioned, we have many different regions. We're going to use just Southern California for 2019 and 2022, and we're also going to use digital notifications sent to these members for that prescription, again for the same time frame. And I think this kind of highlights, this is just a subset of data that we can use in Kaiser at the integrated model, and there's obviously potential to kind of extend this work, but we'll keep the focus here for now. In terms of the analysis, we're going to use just a classic, differences and differences approach. And so just to make everything very concrete, in the treatment, we have members who have opted in to refill notifications within 100 days of that rollout on KP.org. And then for the control, we're going to use the never treated members who never sign up nor receive notifications through any channel. And in terms of that time period, the feature was released December 20 of 2020, and so we're going to be splitting our time frame, our years, into 100-day periods, pre and post. And obviously one of the important parts of this feature, which we'll talk about, is that this is an opt-in feature, and so members are opting in, they're choosing to actually enroll in these refill reminders. In terms of our outcomes, so I mentioned adherence and overutilization. So adherence, very simply, a member who has more than 0 days supply when they refill their prescription, or if they just refill that prescription on that 100th day, we consider them adherent. For overutilization, you can obviously think about this in many different ways. After conversations with pharmacy, we decided to land on 40 days supply. And so if a member has more than 40 days supply, and then they refill that prescription, we consider that medication overutilization. So they have 40 days supply, then they're ordering another 100 days supply, so they'll have 140 days supply on hand. And so just to be clear, overutilization doesn't necessarily mean a member is taking too much of that medication, right? Especially in this case, we're talking about a maintenance medication. It's very standard. It's more likely that they just have more medication on hand than necessary. So in terms of the business rules, so how are these refill reminders actually sent? How do members actually refill these prescriptions? business rules allow refills at 80% utilization from their most recent fill, which is obviously going to be very essential. And so if a prescription is written for 100-day supply, like the ones we have here, a member can choose to refill that prescription after 80 days. And if a member signed up for those notifications, they will receive a reminder at that 80th day that their prescription is eligible to refill. And so here I've kind of plotted out two potential timelines, one for a perfectly adherent member, and then one for a member who's overutilizing medication. And so here you have like the day, so this is their first fill of that medication, and they'll have a 100-day supply. And you can see basically, we're going a long time here. And so the unparenthesized numbers are the days, and the numbers in parentheses are the number day supply that they will have at that day. And so you can see if I'm a perfectly adherent member, on day 100, I refill that prescription, and I again have a 100-day supply at my disposal. Whereas on the bottom, you can see at day 80, this is obviously an extreme case, but at day 80, they've chosen to refill their prescription, and so they now have a 120-day supply. And then you can see how very quickly, on day 400, if you've refilled in this manner, you can actually have 200-day supply. So that's an entire extra prescription or dispense of that medication than that patient needs. And so in terms of how we actually set this up, what we're measuring, we're going to be, like I said, splitting up time into a 100-day supply and looking at members' most recent fill and what their status was at that fill. So if they have more than 40-day supply, so basically if they're here, when they refill, they have 140 of day supply, then we consider that member as overutilizing that medication. So just a 0-1. And the same for adherence is going to be a 0-1 outcome. So let's just jump straight into the average treatment effects. So on the top we have overutilization, and on the bottom plot we have medication adherence. And you can see, so for both of these metrics, parallel trends are, the pre-treatment trends, all are within 0, and then as soon as the rollout happens, both of these metrics kick up. Adherence is pretty immediate, as you expect, given how that's constructed, whereas overutilization takes a little bit more time. But in terms of the magnitudes we're talking about somewhere between 10 and 15% percentage points of members who are either increasing their medication adherence or overutilizing that medication. So it's relatively similar, actually, in terms of the magnitudes. And so, long story short is that refill reminders are causing both adherence and overutilization, right? And so, bringing this back to the pharmacy, what does the pharmacy group want to accomplish? They want all the adherence without any of the utilization, right? Or the overutilization, rather. And so, with this evidence, essentially what they've been able to do, they've been able to very concretely argue that the first and most obvious thing is we need to change that business rule that I mentioned here, which is allowing refills at 80% utilization. And so right now we're going through tests in terms of how we actually set up this rule to try and achieve that, hopefully achievable goal of getting adherence without that overutilization. The other thing that the business has been able to do with this is to, now that we've validated, we know that refill reminders is helping adherence, that's just step one, right? We've only just now learned that this feature has helped improve adherence. And so this has basically led the business to adopt different features or try and test different features to try and squeeze this a little bit more and try and see if we can increase that adherence. And so in terms of examples, we're talking about personalizing the timing of these refill reminders to try and get the member to order that prescription at like the best time of day for them. And so we're excited about this work and continuing to apply these methods in this space. And you can see this is just we're very much scraping the surface here in terms of the capabilities of this data and the integrated model using causal inference. Thank you.
How do you account for the different populations of people who sign up for notifications? Maybe some more technologically competent, and then people who don't sign up for reminders.
Yeah, that's a great question. So, I mean, the first and the most comforting thing that we have to do with differences and differences is looking at these pre-trends, which are, I think, pretty reasonable. So, in terms of the identification here, I think we're feeling pretty safe. And then the other thing, which I didn't present for the sake of brevity, is that in terms of the groups we talked about, right? So in the treatment group, I have members who have opted into refill reminders within 100 days of that rollout. So there are obviously people who enroll at later points in time. And so we also use a staggered approach, which shows basically, very nicely that these things, the effects that we're picking up, these average treatment effects don't show up until a member's actually opted in. And so I think both of these things combined help us, are giving us some sanity that we're picking up as real.
Perfect. Thank you very much.
Thanks.
Thank you both.